Hello and welcome to the Spinal Cord Injury Forum. My name is Heather Barnett and I am the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. I'm also a physician in the Department of Rehab Medicine at Harborview Medical Center. And tonight we are pleased to welcome Dr. Dan Mobley. Dan is an inpatient spinal cord injury clinical pharmacist practitioner at the VA Puget Sound Healthcare System. We are very interested to hear tonight about some background on psilocybin and what research is currently being done. Welcome to Dr. Mobley. Thank you.
Thank you, Heather. Looking forward to speaking to this group tonight. Thank you for the invitation. And I was provided with a list of ideas and decided I couldn't speak to some of them, pregnant patients or children, unfortunately, because of the population I work with at the VA hospital. But the idea of psilocybin and magic mushrooms came up, so I thought that I'd discuss that. And so tonight we'll be discussing a prescription for magic mushrooms, the renewed interest in psilocybin research. So some objectives listed here. We'll be describing what psilocybin is, its mechanism of action, and common adverse effects, as well as examining clinical trial data and recognizing its clinical potential. And we'll be moving into interpreting this data and applying it to the spinal cord injury population. So I have an outline here. We have quite a bit to discuss in the next hour. This will just provide a framework for us. So we'll just start with some background information and close with a focus on SCI population. But first, some disclaimers and disclosures. So I have no financial disclosures to make to the group tonight. I am employed by the VA. However, this presentation does not represent the views of the Department of Veterans Affairs or the U.S. government. And then lastly, it is meant for educational purposes and not considered a substitute for personalized professional medical advice. We'll be discussing some sensitive topics tonight, including self-harm. So I just wanted to bring up some resources for patients and those that providers can share. The Substance Abuse and Mental Health Services Administration, or SAMHSA, Veterans Crisis Line, as well as Poison Control's phone number. Let's begin. What are psychedelics? So throughout, I've integrated some audience participation. I provided ABCD letters for those in person if they'd like to participate. And if you're viewing on Zoom, you can respond in the chat box. Otherwise, you can just chat with individuals who you might be watching this with. So my first question, how many psychedelic drugs can you name right now? So none, one or two, three or four, or maybe five or more. I see a B, I see a C, okay. We can keep moving here too. So let's jump into psychedelics in general. So the term is from a Greek origin word, so meaning to show the mind or the soul. And this was coined back in 1956 by a psychiatrist, Humphrey Osmond. And this term is typically used interchangeably with hallucinogens. And we'll break down a little bit more about different types and what this means. But in general, it's a distortion in a user's perception of time, colors, just overall reality and sounds in themselves. And it can disrupt how someone will be thinking about reality and rationally. And this is sometimes termed a trip or a mystical experience. And psychedelics can be both naturally occurring as well as synthetic or man-made. Some categories here, and I want to note that just because a drug is mentioned here, it is dose dependent. Because you've taken it doesn't mean that you had a psychedelic experience. But two broad classes are dissociative and classical. So the dissociative drugs make a user feel out of control and disconnected from their body, somewhat of an environment of feeling like they're floating on top of themselves. So some examples here, dextromethorphan, which many of you have probably heard of or even taken in cold and cough medicine. Robitussin is a brand name associated with it. You might hear the term robo-tripping, would be the associated term with abusing the medication. There's ketamine, sometimes referred to as special K. There's now a nasal formulation as ketamine also available. PCP is known as angel dust because of its white powder appearance, and then there's salvia as well. Moving over onto the classical side, these can cause more emotions to swing wildly and real-world sensations to appear unreal. This can sometimes be frightening to the user. And these do interact with serotonin and dopamine receptors. So some examples here are DMT. This is also known as businessman's lunch, just because of its kind of shorter activity. And it's the active component in ayahuasca. And there's actually a form of 5-MeO-DMT, and this is secreted by the Colorado river toad. So if you've heard the term licking the toad, this is where this comes from. Then there's LSD, also known as acid, as the name suggests. MDMA is also known as ecstasy, which there's, interestingly, a lot of promising research with this drug as well. There's mescaline, which is found in the peyote cactus. And then lastly, there's psilocybin, which we'll dive into quite a bit tonight. And like I mentioned, it is dose dependent. Just because you've taken one of these medications does not mean that you're having a psychedelic experience. Some background history here. Psychedelics really date back quite a ways, 5,000 to 7,000 BCE. Cave paintings that were identified back in modern day Algeria have been found, and this is linked largely to religious use at the time. Fast forwarding quite a ways to the 16th century, were the first written documentation by Spanish colonizers of the use by indigenous peoples in Mexico. And in 1897, mescaline was isolated from the peyote cactus. And just a little less than 100 years ago, LSD was synthesized by who's been termed the father of LSD, Albert Hofmann, who was a chemist. And not all that long ago, in 1957 and 58, is when the same chemist received Psilocybin mexicana, the actual mushroom, and identified psilocybin structure, and then in 1958 synthesized it. A little bit more history getting closer to modern day. In the 1950s and 60s, of course, the US intelligence community hopped aboard, and they had Project Artichoke and Project MK Ultra by the CIA. And they were investigating interrogation tactics, and psychedelic drugs were one of those that they did investigate. In 1962, ketamine was first synthesized, and it was used quite extensively in the Vietnam War for surgical anesthesia in the field. And during the same decade, in the 60s, you see a lot more counterculture or hippie movement throughout the United States, and that psychedelic use was increasingly associated with that. And there's just a lot going on at the time. And to wrap up the 60s and going into 1970s, when we see the US Controlled Substance Act passed, with psilocybin, along with nearly all the psychedelics being Schedule I controlled substances. And we'll touch on what that means throughout the presentation. So Sandoz, who was the employer of Albert Hofmann, actually marketed and distributed both LSD and psilocybin. Psilocybin was known as indocybin throughout the 60s. However, as the decade progressed, there was more public opinion that was becoming divided, and laws were becoming more strict. Sandoz ceased production of these agents. So psilocybin is, as you might guess, produced by many species of mushrooms, and you can find these throughout the world. Some places listed here, including the United States, including the state of Washington. And the majority of the species are the Psilocybe genus. And important to note is the psilocybin itself, within the mushrooms, the concentration ranges quite a bit, from as low as 0.1% up to a reported 1.5%. So we want to keep that in mind when we discuss different topics throughout the presentation, that this is a 15-fold difference throughout. psilocybin's mechanism of action is going to get a little bit heavy on the science side with the pharmacy background, but it is a serotonin receptor agonist. Its highest affinity, or its preferential binding, is for 5-HT2A. 5-HT is just an abbreviation for serotonin. And unlike LSD, it has no activity on dopamine receptors. So I included here the structure of serotonin next to the structure of psilocybin. And if you kind of mirror the two, they do overlay fairly well. And these 5-HT2A receptors, they're highly concentrated in the central nervous system, and this is what's likely responsible for that dose-dependent mystical effect. So just a quick aside on serotonin. It is a neurotransmitter, and it's responsible for a number of effects throughout the central nervous system as well as peripherally. So there's 15 different types of receptors that have been identified. And it's responsible for a variety of behavioral effects, and a number of medications either directly impact serotonin signaling or the receptors themselves. And outside of the central nervous system, we see serotonin receptors throughout the body. Some that I'd want to mention on would be cardiac, the GI tract, as well as vasculature. And these will play into some of the effects we see from psilocybin. And interestingly, prucalopride is a medication that we'll sometimes use for constipation in the SAI population a little bit further line, but it increases GI motility, and it does that by being a 5-HT4A agonist. So I just like to kind of connect the dots when I can. It's a little bit more science here with pharmacokinetics. And so it is a prodrug, meaning that it is not active itself, the psilocybin. It is rapidly metabolized to psilocin, and psilocin is actually the active metabolite. And this is done by first-pass effect with dephosphorylation in the liver. And so psilocin structure is here. It's very similar. It's just lost the phosphate group. And the onset of action is really quick, 20 to 40 minutes. You can see this dose concentration graph here where you see a peak pretty quick. And the peak is within 1 to 2 hours, and the half-life is 2 to 3 hours. And so the duration of subjective effects has been reported in that 3 to 6 hours window. So some clinical questions to consider at this point as we've been talking. So does the dose depend on renal function? And the answer is no. Does it depend on body weight? It's also a no, just in some of the pharmacokinetic models that have been done. And what if you were to be doing repeat dosing? So you can develop tolerance, and so you would see a decreased effect with repeated dosing, and you can see cross-tolerance with LSD. So someone who is a repeated LSD user who would then use psilocybin may not have the same effect as someone who is naive to using psilocybin. So what's the optimal dose? And this varies quite a bit, and you can start to see initial effects that are not hallucinogenic. At 3 milligrams to 10 milligrams has been reported, and these more mystical experiences are higher, 10 to 25 and beyond. And 25 milligrams will come up again in the presentation. So with psilocybin, we're not just simply sending someone home from the pharmacy with psilocybin. There's a lot to go into with logistics. There's multiple sessions at play. And so I guess just jumping ahead, there's both oral and IV formulations that are being investigated. And a synthetic form provides a standardized dose so that you're not relying on a natural mushroom where the psilocybin concentration can be variable. And like I mentioned, it's multiple sessions with psychological support. So you'll see preparatory sessions, a dosing session, and then integration sessions that follow the dosing session. And so the dose itself is typically a longer day. Like I said, the effects can last for multiple hours. So it's done in a 6 to 10 hour session in a comfortable room, which I'll show an example picture on the next slide with a couch. It's a non-clinical setting. There's typically 2 trained facilitators on hand. This is largely because during a psychedelic experience, you are in a vulnerable state. Having a second individual allows for some, I guess, warranty against some inappropriate behavior that could go on. Eyeshadows and eye shades are encouraged so that you're really thinking introspective about the experience itself. And there is musical playlists out there that are used in these trials, and there's different phases of the musical playlist to try to match the experience that the user is experiencing. So here's an example image of the University of Wisconsin-Madison's psilocybin dosing room. And so you can tell here it's the lighting is not like a typical hospital room by any means, or even a clinical room. And you have a couch in there. You have some wireless headphones, as well as the eye shades sitting right next to it. So keep this kind of structure in mind as we move into the clinical research and we talk about how these trials were structured. So next point for some audience participation. So what type of clinical research do you think has been published on psilocybin? So A, there's no studies at all, and it's simply expert opinion. Or B, various case reports from recreational users. Or there's C, randomized, placebo-controlled, double-blinded trials. We will be discussing some randomized, placebo-controlled, double-blinded trials, and just to take a step back and talk about what that means, we have a hierarchy of how we think about scientific studies. As we progress higher on the pyramid, our quality of evidence increases and our risk of bias should decrease. And so a randomized trial just indicating that subjects are being placed into the trial and being randomly assigned to different groups. There is a placebo or a dummy pill involved. And double-blinded, meaning that neither the subject in the trial nor the investigator who's working with the subject knows who is assigned to what. So back to some history here. The very first section, 1970, is the exact same, but we had quite an extended period where not a whole lot of research was going on until the early 2000s, where we see a renewed interest in psilocybin and research of significant and sustained psychological effects. And there's, moving into the early 2010s, there was research in treating depression and anxiety for patients with life-threatening cancer diagnoses. And a breakthrough therapy was granted from the FDA for treatment-resistant depression and major depressive disorder. So we'll really dive into these studies as opposed to more of the cancer diagnosis considering our group this evening. It's important to note, though, that the areas of research are vast and keeps growing. You could probably add another image here, but we have various forms of depression, like I mentioned, as well as the end-of-life anxiety, PTSD, different types of substance use disorder, including alcohol, cocaine, methamphetamine, nicotine, and opioids, cluster headache, OCD. And so I'm sure that come summer, you could add a couple more around the psilocybin. So we're going to really dive into and do a closer review of these select trials. These were randomized, and they're more general conditions that can be applied. And we're not going to review them in chronological order, but I've structured them here where I think it'll make sense to walk through. So the first is a single-dose psilocybin for a treatment-resistant episode of major depression. And this was published just back in 2022 in New England Journal of Medicine. The population were adults with a current episode of depression that had not responded to 2 to 4 adequate trials of treatment. And so this is maybe a more challenging population to really achieve treating the depression. So the design is a double-blind, randomized, and is actually a dose-finding trial. And I'll mention that on the next slide, what that meant. A variety of countries. This was conducted in from 2019 to 2021. And they had a run-in period to taper off of antidepressant medications. And this was likely in part to standardize the population, as well as SSRIs may actually blunt the response And then MAOIs are contraindicated with psilocybin. And so the visit structure, similar to how I was alluding to, they had 3 prior to the administration that focused on trust building, education, and preparation. The administration session itself was 6 to 8 hours. The day after the administration, they had another integration session. And then a week after this, they also had an integration session. So like I mentioned, it's a dose-finding study. So they used 1 milligram as a control, and then 10 milligrams and 25 milligrams to try to identify an optimal dose. And the primary outcome was a change from baseline to 3 weeks in depression rating scale. And so we have the results here. Is 233 participants, and a lower score indicates less depressed. So as we move down, we see better outcomes. And as a reminder, the outcome was at 3 weeks. However, they did continue to report data beyond that. And so the big takeaway here was that, as you can see with the blue line, the 25 milligram dose was statistically significant over that 1 milligram dose. And meanwhile, the 10 milligram and the 1 milligram did not have much of a difference at 3 weeks. So that really sets the 25 milligram dose apart from the other 2. So the next study is from JAMA and just published in 2023. And it's a single-dose psilocybin treatment for major depressive disorder. And this included adults with a current depressive episode of at least 60 days. And the design here, too, was double-blinded, randomized. They used an active placebo, which was niacin. And the reason for this was niacin can produce a flushing sensation and appearance, and they were trying to keep everyone blinded or unknown to which they were getting as best as they could. And they were trying to mimic what someone taking psilocybin might appear. This was only done in the United States from 2019 to 2022, and they too had a run-in period where they were tapering off of antidepressant medications. So here we had scheduled visits again, multiple sessions totaling 6 to 8 hours before the administration. Their administration session itself was 7 to 10 hours, and then they also had multiple integration sessions afterwards. So their doses are listed here. They did 25 milligrams of psilocybin, and their primary outcome was the same rating score, but at 43 days, so effectively 6 weeks. So looking even farther out. They had fewer patients, 104 participants, and here again, the lower the score, the better. And psilocybin once again achieves statistical significance in comparison to niacin at this 43-day mark. The last study that we'll review is a trial of psilocybin versus escitalopram for depression. And so escitalopram is an SSRI, and so in this case, they have an active comparator. And here again, it was long-standing, moderate to severe major depressive disorder was the population. It was exclusively done in the UK and just a handful of years ago. This one's a little bit different too, where they actually do 2 doses of psilocybin while they're titrating up the escitalopram. So their scheduled visits was the day before the dose, the first dose, the day after the first dose, and then they repeated the dose 3 weeks later, and they had a final visit 3 weeks after that. And so the groups were broken down where they had 25 milligrams psilocybin on that 2 different weeks that were 3 weeks apart, and then they had daily placebo that they were taking throughout. And the other group, they had a 1 milligram psilocybin, here again trying to have an active type of placebo in a sense that would be below the psychedelic dose that you'd expect. And they were taking escitalopram 10 milligrams for the first 3 weeks and then titrating up to 20 milligrams for the last 3 weeks. And their change from baseline was at 6 weeks and another depressive symptom score. And so just a reminder, at day 0 was the first dose, week 3 was the second dose, and then we're looking all the way out at week 6. a smaller population of 59 participants. The main takeaway was that there was no significant difference between psilocybin and escitalopram. So the big takeaways from the 3 trials would be that 25 milligrams of psilocybin was statistically better than 1 milligram at 3 weeks, that the 25 milligram of psilocybin was better than niacin at 6 weeks, and psilocybin and escitalopram, really no difference observed. So how are we getting these long effects when I told you at the beginning the half-life is just 2 to 3 hours? You're getting it out of your system within the same day, yet we're seeing these positive effects weeks later. And it's this thought about durability with psilocybin, and that there's multiple theories out there as far as why that is, if it's the mystical experience that's allowing introspection and allowing you to visit issues in different light, if it's the importance of the psychological therapy that's being coupled with it, and maybe the psychedelic is opening you up more to having those psychological therapy sessions. Or it could be neuroplasticity. This is the idea of new connections in your central nervous system, reorganizing structure and function and making new connections, and just kind of reorganizing your thoughts. And it's possible that all 3 of them are playing into it together. So I've talked about some positives, and now we'll move into safety and risks. So is psilocybin right for everyone? Yes or no? I'm seeing some no's here, all no's. So yes, I want to highlight first that these trials excluded a variety of populations, those who personally or first-degree family history of psychosis or mania. So this would be schizophrenia or type 1 bipolar mania. And the thought was that psychedelic experience might exacerbate this type of condition, and thoughts might be too unorganized, that the risk may supersede the benefit potentially. Active suicidal ideation with intent or plan, as well as suicidal behavior in the last 12 months was excluded. We'll talk a little bit more about this in a few slides. Those who are pregnant, and then just a general medically significant condition, the investigators were allowed to exclude. So this allowed for a lot of latitude with exclusions, unfortunately. Some common side effects that were observed. Headache was reported as many as 2/3 of the participants. Nausea was as many as 1/4 to 1/2 of participants. And this is where we can think back to some of the earlier slides with where does serotonin bind in our body. And like I mentioned, the GI tract was one of them. And that psilocybin, although it has highest affinity for 5-HT2A, it likely has some affinity for other serotonin receptors too. And visual perceptual effects were reported, just thinking about distortions in reality as well as fatigue. And these side effects were often mild and self-limiting and limited to the dosing session day itself. Additional side effects would be reported as anxiety or feeling jittery. This is colloquially known as just a bad trip. And not many of these individuals required any intervention. It was very rare that someone would require a benzodiazepine or anxiolytic for this. Otherwise, for the most part, the facilitators could act as a guide and provide reassurance during the session itself. And this really harps on the importance of the initial screening and then the presence of the facilitators as well. Some reports of hypertension, as much as 20 to 30 millimeters of mercury increase systolically, and this typically corresponds with that peak concentration within an hour or 2 of taking the medication. Bradycardia and tachycardia were reported, more so on the tachycardia side. And interestingly, hyperreflexia has been noted throughout some past studies, indicating reduced threshold of patellar reflex, increased deep tendon reflex, and it was as high as 80% in one report. So we'll touch back on that in a little bit. So psilocybin and suicide risk, it's a little bit difficult at this time to draw conclusions. There were variable results from reduction in suicidal thinking to no impact to actual worsening of a suicidal state. So the JAMA trial, that was the niacin versus psilocybin. They had no suicidal behavior that was reported amongst participants. The New England Journal of Medicine dose-finding trial, where we did 1, 10, and 25 milligrams, they actually noted an increase in passive suicidal ideation, and that 3 participants reported suicidal behavior after that 3rd week. Otherwise, there are self-reporting studies out there that indicate a possible reduction in suicidal ideation. So it's difficult at this time to really draw conclusions. As far as dependence and toxicity, there's no evidence of physical dependence or withdrawal, and that the risk of overdose toxicity is pretty low. It's lower in comparison to medications such as aspirin or substances such as nicotine. And the theoretical lethal dose is likely about 1,000 times an effective dose. So if you think about it from a mushroom perspective, you'd have to eat grams and grams of mushrooms, and you would likely vomit before you achieve that. However, now that we move into more synthetic psilocybin, in theory, I guess it'd be easier to achieve, unfortunately. But it's likely not possible with natural mushrooms. So now thinking about drug harms, and this is from a group from the United Kingdom, an expert panel assigning overall risk, and they summed the risk to users and the risks and harms to others in society to different substances using a standardized scale. And so the blue that's on the top here, that's the perceived harm to the users. That might be physical toxicity, overdose, accidents, overall morbidity, mortality. And the red is the harm to others. So we have a audience participation here. Where do you think psilocybin's harms rank relative to other drugs? We have A, which would be suggestive of the most harmful that they compared. B, more middle of the road. C, even less. Or D, the least harmful with respect to other drugs. So A would be the most harmful substance that they viewed. So we had a couple of C guesses here, and it's actually the least. So they classified it as mushrooms, and it was ranked as the least harmful drug compared to others, and the risks were really placed on the user of psilocybin or mushrooms. It's interesting just to take a brief glance at the bottom x-axis there, with alcohol being the most harmful drug collectively to both users and to society as a whole. And so thinking about psilocybin and the risks to users, it's most likely related to using psilocybin in an unsafe setting, with accidents possibly occurring, maybe no supportive staff, or individuals who are also present maybe under the influence as well, or mixing psilocybin with other substances could place you at harm. So just because it's low risk doesn't mean it's no risk. And these are just, you don't have to look far for some negative publicity. As far as Wallace Falls State Park is not far from here. And then the Alaska Airlines pilot situation is, there's probably more going on there than what meets the headline. I know that it was reported that the individual had used mushrooms a couple days prior, so the overall impact is a little bit unclear. But you don't have to look far, so this really emphasizes that the setting and patient selection matters when thinking about psilocybin. So microdosing has become definitely a common term, hot topic buzzword. So another audience participation, are you familiar with the concept of psilocybin microdosing? If so, when did you first hear about it? So maybe you haven't heard about it, or you have within the last year or so, or you have within the last 1 to 5 years, or over 5 years ago. So we got an A, we got an A, B, and C. Okay, I like it. And so first off, what is microdosing? And it's routine, very low sub-perceptual, so below that mystical experience, doses of a psychedelic. And you could be doing this for a variety of reasons, trying to maybe improve cognitive function, mental health, pain, the list goes on. And this is actually not a new concept. Mr. Albert Hofmann theorized it himself back in the 1970s with just microdosing LSD and possible benefits with that. So it's actually a pretty old idea. So the evidence surrounding it is limited. There's an observational study that was published just in the last couple of years that had 98 microdosing participants, and they had the daily emails sent out over a 6-week period, and there was reported general increase in psychologic function on dosing days. And they defined psychologic function as mental health, attention, well-being, mindfulness, mystical experiences, personality, and creativity. Meanwhile, there was a placebo-controlled study that was done with 34 participants, so very small, and the subjects were not told what they would be receiving, and these individuals were already planning to start microdosing. So they received either half a gram of dried psilocybin mushroom or a placebo for 2 weeks, and they concluded that there was lacking supportive evidence of improved cognitive function, creativity, or well-being. So the results are conflicting at this time amongst the two. It was noted that 3/4 of the participants correctly guessed what they were taking, whether it was the placebo or the dried psilocybin. But they did overall notice subjective effects from microdosing for that 2-week period. So some risks versus benefits here. Thinking about it, where individuals who are microdosing, you're receiving variable doses, and it's an unregulated supply at this point in time. And like I mentioned, this psilocybin concentration can vary quite a bit. And so you have the potential of maybe taking more one day than you anticipated, and you wouldn't want to be in a situation where you're driving a vehicle or needing to be focused and having impaired cognition when you weren't expecting it. It is federally illegal at this time. We'll talk more about the legal status next. And then also I mentioned the idea of tolerance. So it's hard to know, if you're building up tolerance to the medication, how much additional benefit are you getting with each day. So there's a lot unknown at this time as far as should you do it for 2 weeks on, 2 weeks off. And it goes back to the initial studies too that I discussed. Is one dose enough? Do you have to redose again later? So there's a lot of unknown out there too. So possible benefits though were reported. So I would conclude though at this time more information is needed. So it's begging the question though, do you need the mystical experience, or are you achieving some constant neuroplasticity throughout time? And it's hard to tease that out. So the legal status of psilocybin, it's pretty complicated. So we'll start off with a question here, which is true. The federal government classifies psilocybin and cocaine in the same drug schedule. The Seattle Police Department is encouraged to actively arrest and prosecute anyone using psilocybin. Washington has no plans to investigate the therapeutic potential of psilocybin. And D, Oregon has a formal licensure system for a psilocybin treatment system. So which is true? We have an A in the chat, we have an A in person, and D as well. So we'll conclude that D is correct, and we'll discuss through those. So here's the US DEA drug scheduling, and so essentially it's how addictive or what the potential for abuse may be, and there's 5 different schedules with Roman numerals. So Schedule 1 is the highest potential for abuse with no medical use. So currently this includes psilocybin, heroin, LSD, marijuana. Schedule 2 is high potential for abuse again, however, there is a medical use for it. And this is actually where cocaine falls in, as well as Adderall, fentanyl, oxycodone. Schedule 3 is moderate to low abuse. Schedule 4 is even less. This is where we'll see diazepam, tramadol, zolpidem. This is where these medications fall. Then Schedule 5 is very low. This is where pregabalin is listed. So some common medications that we might see in our SCI population. So I'm not asking if you agree or disagree with the scheduling, but this is how it currently is. The city of Seattle has a resolution from 2021. The city council mentioned that the investigation, arrest, and prosecution of anyone should be among the city of Seattle's lowest law enforcement priorities, in stating the council's support for full decriminalization of these activities, and that included psilocybin mushrooms, is how they listed it. And so Seattle is not alone in this. There are a handful of cities across the United States that have decriminalized psilocybin. How about here in Washington State? And just last year, the Washington State Senate passed a bill that created a state psilocybin work group, as well as it mandated University of Washington to facilitate a clinical pilot program. And I'll mention that other states, and it's an election year, so I'll mention that both conservative and liberal states are pushing for consideration of psilocybin for clinical uses. So I'll play this very brief 1-minute clip from the University of Washington so that you don't have to listen to me for an extra minute.
The University of Washington School of Medicine's Department of Psychiatry and Behavioral Sciences will run a psilocybin therapy study, which will begin by January 1st, 2025.
Right now, what we're anticipating is studying people who are veterans or first responders who meet diagnostic criteria for PTSD, post-traumatic stress disorder, who also meet diagnostic criteria for alcohol use disorder. Our hope is that in targeting this specific population with these two comorbidities, that we could better understand if this could be a viable treatment moving forward. So I think there's a big distinction there, that when people often hear, oh, you're going to give psychedelic mushrooms to people, like that's odd, right? What I always explain is that this is in a very controlled environment. It occurs within the setting of a therapy where you have kind of preparatory sessions with your therapist. You then have the psychedelic experience under the observation of generally 2 therapists, and then you have therapy thereafter. All of this is in a controlled environment with medical professionals, and I think it's important that we explore all options available to us to potentially help people. And psilocybin, from the data that's available, really does seem to show a lot of promise for some pathologies that we have had very limited success in treating.
That is the current state in Washington State. Now moving to our neighbors to the south in Oregon. Just a few years ago in 2020, voters passed legalizing psilocybin in a therapeutic framework. And so what this means is they have begun licensing facilitators who have finished training programs just about a year ago. And licenses were being handed out to manufacturers. And then moving along, there's two testing labs in the state that test for the concentration of psilocybin. Then they call them service centers, and these are the actual settings that the dosing is being done. And reported at the end of last year was that over 700 people access these services in Oregon. So even though you can't legally access here in Washington State, you could travel not too far to access it in Oregon in a therapeutic setting. And interestingly, some of these service centers or treatment programs report that majority of their patients are coming from out of state. And one even mentions on their website that they are located conveniently near the airport for your psychedelic tourist. So a little bit more information with the Oregon program. It's restricted to those who are 21 years and older. You don't need a prescription or a medical referral at all. It is somewhat cost prohibitive, anywhere from $1,500 all the way up to over $4,000 for a dosing session. And this includes the preparatory sessions, the dosing session itself, and these post-dose integration sessions are optional within the state of Oregon. I'll mention too that it's still a Scheduled 1 controlled substance, so interestingly, these payments are being made through third-party apps or cash because credit cards don't want to be involved with this at all, and it also would be illegal to transport it across state lines. So finally, I've been talking for a little bit now, and I haven't really focused on spinal cord injury population yet. So we'll finally have a focus on this. And probably not, unfortunately, a surprise, but it was a population excluded in the studies. And so in these trials, they excluded, like I mentioned, those medically significant conditions, which were really broad and vastly reaching, or a major concurrent condition is how it was listed too. So there's no available randomized placebo-controlled trial data for SCI patients. However, we do have some observational data that we can look at with a couple of recent publications, including a poster presentation from a group out of the University of Minnesota. And interestingly, if you look online, the Minnesota Regional Spinal Cord Injury Model System group, which I think correlates well with this group, did a similar presentation not too long ago and invited one of these researchers on to discuss. So you can go find that discussion too. So the first publication was persons with spinal cord injury report peripherally dominant serotonin-like syndrome after use of serotonergic psychedelics. This is published last year in 2023, and they searched online forums for use of psychedelics with spinal cord injury, and 12 users were identified, and the reported experiences varied, both positive and negative. Some reporting intense leg spasms, dehydration, cold sweats, overheating, urinary incontinence. Others mentioned that it changed their life with respect to PTSD. And this group goes on to theorize that the symptoms might be what they term a peripheral serotonin-like syndrome. And serotonin syndrome is something that gives us pause in the medical community, where oftentimes it is medication related, and it can cause mild symptoms with diarrhea or nausea, or it can be more severe, such as high fever and seizures. And so their thought is that in this patient population, spinal cord injury, you may see an upregulation in serotonin receptors in the periphery that creates this hypersensitivity state, where then you introduce a psychedelic agent that then may place you at risk of spasms and more autonomic symptoms there. The poster presentation utilized an online anonymous survey for individuals who have spinal cord injury and who have used psilocybin. It's important that the last publication was psychedelics in general. This was more focused strictly on psilocybin. They included 19 responses with the demographics listed here, predominantly male, predominantly cervical level injuries that were chronic in nature. So they report on reduction in pain. So it's interesting, almost all reported a reduction in pain from their uses, and they have red for cervical level of injuries, blue for thoracic, and green for the lumbar. It's important to note it was a small sample size, but they have a grouping of your level of injury versus the individuals listed here. Also note on the impact on muscle spasms. And this was varied for both frequency and severity. And they noticed that cervical level injuries reported more spasms, becoming more frequent and more severe in nature. And so this links back to some of those initial studies that I mentioned where there is reported hyperreflexia noted amongst patients. So the dots are connecting a little bit that could be a cause here with psilocybin. And so when we start to make some conclusions from this data that was observational and self-reported, it's important to note that individuals with spinal cord injury are using psilocybin and other psychedelics for a variety of reasons, and that there's possible improvements in pain control and mental health, but there's also that possibility of worsening spasms and more of those autonomic symptoms that we might see with the use. Like I mentioned, very few reports that we have at this time. Also considering how these individuals would be receiving and obtaining psilocybin or other substances, it would be in an unregulated setting. Hard to know what doses people were doing, if it was not enough, way too much, and then also just lacking the integration with the psychological support. So I'd say at this time, unfortunately, it's difficult to draw conclusions, but individuals with SCI are seeking psychedelics. So some specific physiological considerations to make with risks as far as thinking about nausea and spasms, could cause autonomic dysreflexia, increased fall risk if you're going to be performing a transfer and may not have your perception of reality there at the time. Pressure injury risk, thinking about your perception of time and that a lot of time might pass and you may not realize it. Inability to perform intermittent cath programs if you're not cognitively aware of both the time and the need to do that. And unfortunately, it's not uncommon to need to take medications throughout the day, and these subjective effects can last for many hours, so the ability to take medications throughout a possible dosing session needs to be considered. Possible benefits, though, they're definitely there as far as depression and mood, maybe helping out with chronic pain, PTSD, and substance use disorders. So I would be hesitant to say that a blanket statement of just stay away, because there could be potential benefits, but it's that identifying the correct patient to be utilizing it. So I discourage clinicians from using a tone of just don't do it. I think we should take more of a risk management and risk reduction perspective. Otherwise, we might be isolating patients and forcing them to find information elsewhere where it may not be as reliable. So asking yourself or asking your patient, what is the goal here? What else have you maybe tried? Have we exhausted other resources here? Do I have any current thoughts of self-harm? Would be a reason to discourage its use, at least at this time, based on the information that we have. What setting will you be in? Is it going to be a safe setting? Will you have, maybe you're going to be going to Oregon to be doing this? Are your facilitators familiar with spinal cord injury? Will you be having a caregiver assist you? Will individuals understand how to manage AD if that's something that you're at risk of? Or performing intermittent cathing if that's something that all of a sudden you're unable to do? And if you need routine medications, will you be able to take those? And like I mentioned, transferring safely, performing pressure releases, having that facilitator, someone who is not also undergoing an experience who could help guide that situation. And any concurrent medications that you're taking that might attenuate or blunt the response. There's a variety of medications out there that aren't uncommon in the SCI population. So antipsychotics, ciprofloxacin is actually a serotonin antagonist, diazepam, SSRIs, SNRIs, TCAs, and the list goes on. So, thinking back to the initial trials that I reported on, individuals tapered off of these medications for 2 weeks beforehand, and that might or might not be a possibility for you or your patient to safely come off of that medication. And if they remain on it, it might kind of blunt the response altogether, and you may just be getting the risks and not much of the benefit. So finally, I have some closing thoughts here. Just some limitations with the trials, thinking about small sample sizes across the board, the possibility of just unblinding, knowing whether or not you received psilocybin might impact your perception of how well it worked. Limited duration, thinking about outcomes at 3 weeks or 6 weeks is pretty short duration. Unfortunately, a lack of ethnic and racial diversity in these studies, which is very unfortunate considering where psilocybin and its use really originated from with indigenous peoples. And lack of medical diversity too, so just the vast exclusion criteria that I mentioned. And then the practical limitations at play. The time commitment to go in and do preparatory sessions, taking a full day to do a dosing session, and then sessions afterwards is a big ask for an individual, and also with staff, that staff may end up being more of a bottleneck in the future as it's becoming more prominent. And so thinking about that as a limiting factor, and it's very expensive, and being able to access it from a cost perspective. And like I mentioned on the last section, the ability to taper off of certain medications to match how it was done in the studies. So some unanswered questions I've listed throughout here. How important is that mystical experience? It's interesting, they're undergoing trials with psilocybin and midazolam, a benzodiazepine, to try to have you forget the mystical experience to see what that factor is. The importance of the elements of the setting, there's more of a push to personalize the music, allowing the user to pick what music they wish to listen to, as well as using more television monitors to have images display that they want, as opposed to just stagnant art on the wall that might not culturally match their beliefs. And just how durable is the response? I mentioned the shorter duration, so we don't know just how long the response might be and whether or not we need to be redosing throughout. And what is the true benefit of microdosing? I think the jury is still out on that. And the thought of, can we expand the ratio of participants to facilitators to improve access? So instead of 2 facilitators and 1 user, if you could do 4 to 8, there's different combinations there that you can come up with to improve access. So here are just a few recent University of Washington trials. The first one was frontline clinician psilocybin study, and it was assessing short and long-term effects of psilocybin-assisted psychotherapy on symptoms of depression, and that was experienced by physicians and nurses with frontline exposure to COVID pandemic. So this is already an active study I believe it's already done recruiting, and it's just undergoing now. Also here at the University of Washington, looking at treatment for cancer-related anxiety in patients with metastatic cancer. And over within the VA, there's more of a push to fund studies on new therapies, including psilocybin. And like I mentioned with that video, that will be hopefully enrolling by 2025, maybe the end of 2024. So some final reminders: psilocybin is not for everyone, and it's also not a magic bullet. So just because it did show improvement, it didn't mean that it worked for every single person in that group. So it was not 100% effective. And it should also be considered as an adjunctive therapy with psychological support, considering how those sessions were integrated amongst psychological support. So I just want to close with some special thanks to actually one of my former professors, Paul Hudson. He's over at University of Madison, and he's the director of their Transdisciplinary Center for Research in Psychoactive Substances. And he actually has a link to the University of Washington, as he went here back in the 70s for his degrees. And he and I were communicating over email about psilocybin and SCI population, just to pick his brain. He is also a pilot, because why not? And as a student, part of a fundraiser, I got to go up in his plane with him, with another classmate of mine, Aaron. And you'll notice that he was a co-author on a couple of the studies that we talked about this evening. I'm happy to address questions and comments now. I know that folks are pulling up the chat window too.
You were talking about this serotonin-like syndrome and spasticity. Do you have thoughts about the other psychedelic agents, and if that would have if those would have similar issues, or if something that's working on a slightly different system would be different? Has any of that been looked at?
That's a good question. So I will say that publication did look at psychedelics in general. So it was reported with other substances. Off the top of my head, I do remember LSD was being mentioned too. But it begs the question, those are the classical hallucinogens. If you think more about the dissociative class, it's hard to know if you draw similar conclusions thinking about the receptors being different. So I know that MDMA is definitely closer, and that is more of a classical hallucinogen, but it is probably closer to FDA approval than even psilocybin is. But thinking about ketamine and its dissociative properties, I'd say it's hard to conclude if you'd see that same peripheral serotonin-like syndrome. I'd argue that you probably wouldn't, but I don't have any data to back me up on that.
We do have a couple of questions here. So one of the questions was about the studies at the VA. Are those in specific locations? So where are those studies listed, or can they find them somewhere? And then are the studies listed only for veterans, or would other people be eligible?
Good question. So this headline here is just from last month, January 5th, 2024. So I don't have the information in front of me to be able to cite specific ongoing studies. I just know that there's currently a push. Now, the University of Washington study within that population that they're looking at is including veterans, and that was back in the video clip that I played. That is not currently recruiting. However, I guess I would be looking at University of Washington's just medicine updates with research. It's a little tedious, but clinicaltrials.gov is always a place to look, but it can be challenging to identify who's recruiting and where it's being recruited at. A lot of the studies that I brought up were able to recruit just based off of word of mouth. So at this time, I don't have any specific studies to cite that the VA is enrolling, but I guess I would get in touch with your VA provider throughout this coming year and next, because there are definitely going to be studies ramping up based on the funding, and they can always reach out to their VA pharmacist for more guidance too.
Another question. It's great info that you've provided so far. Some of the anecdotal info says there may be functional recovery potential. Are there any SCI clinical trials addressing that?
I've heard peripherally with the functional recovery aspect. However, as I think the question mentioned, anecdotally, there's not a whole lot of supportive evidence out there. As far as studies investigating that, I don't know of any at this time that are looking at that.
Does psilocybin seem to be one of the more popular psychedelic medication? So is this kind of one of the, I think I've also heard quite a bit about ketamine recently. Are those sort of the big two, so to speak, or is everything on the horizon right now?
In terms of clinical application, or in terms of just generally clinical application? Yeah, as we know, ketamine's already an approved Schedule III substance that we use, both for a variety of reasons. And I would say that MDMA is actually probably closer, as I mentioned, to an FDA approval than psilocybin. I would be willing to bet that by the end of this decade, both will have received FDA approval. Some are predicting even in the next couple of years for MDMA. And so psilocybin, as opposed to maybe LSD, psilocybin is really focused more on because it had a little bit more studies done back in the 60s and 50s, and that its onset and duration of action is shorter than you see with LSD, so you can achieve a dosing period in a shorter time frame than LSD, where the length of time for the effects is longer. So my understanding is that's why psilocybin was pursued for its clinical applications.
Question from the chat here. You had talked about increased spasms, but what about pain? Can you talk a little bit more about pain relief?
Yeah, pain, as we know, is such a multifactorial issue for a lot of us. And so I'll bring back up the poster results here. So it was a variety. For some individuals, experiencing spasms will be painful, and that I think would correlate with a worsening pain control. That's not always the case for others. As far as why does it work for pain, I couldn't address that mechanistically, but that it has been reported as a pain reduction for some groups. So unfortunately, I'd say again, more information is needed, but it is an interesting thought that a single dose potentially could provide pain relief for a durable response.
Somewhat related to that, do you know if there are any studies planned to investigate the pain relief effects of the drug, or are the studies more just focused on the depression and other things?
Yeah, so this links back to the FDA's breakthrough therapy designation, and that was really for treatment-resistant depression and major depressive disorder. So to be able to use it in a clinical trial setting would be for either of those indications at this time. And so it's important to note that individuals in those studies, that's not technically illegal because it's got that FDA granted status. So that would require the FDA to then approve it for breakthrough for pain relief, or if it's something that maybe the next study looks at as maybe a secondary outcome would be another possibility I would think of. But of course, once a medication is approved, we often use medications off-label, so that would be tough to track that data too at that time without studies. At that point, yeah, it'd be a little easier to do studies if it's not a Scheduled I substance.
Yeah. Dr. Mobley's presentation gave us all quite a lot of information. So I'll come up here and thank him, and then if there's any other questions, just let me know.
Perfect. Thank you all. Thank you,
yeah.
Heather, for having me.
Thank you. So thank you all so much for joining us. I hope you learned something tonight. I certainly learned a lot. That's all we have time for tonight. Thank you to Dr. Mobley. Thank you all for coming. And just a brief reminder to please fill out the survey and let us know if you have any thoughts or preferences on additional topics, as well as your feedback on this particular discussion will be very important for us. So thank you all so much, and I look forward to seeing you all again soon.